Thank you so much for allowing me to speak. I'm going to be speaking about CELS. These are my disclosures. So we all know that the best way to prevent colon cancer is through the removal of polyps. And I think we would all agree that the best way to remove polyps that appear to be benign is endoscopically at the time of colonoscopy. However, about 10 to 15% of colon polyps are going to be what we consider complex, meaning they're either large or broad-based or located behind a fold, and it makes it really difficult to resect them endoscopically, and sometimes it's just not possible. These polyps can sometimes be resected with advanced techniques such as EMR or ESD, but if surgeons are not comfortable with that method, or endoscopists are not uncomfortable with that method, then patients often end up having colon resections for these polyps. The problem with colectomy is that it's associated with significant morbidity even when it's performed laparoscopically. So things like leaks, higher costs, and prolonged hospital stays make colectomy a suboptimal method to remove benign polyps. However, CELS may be an effective alternative to colon resection, and one of the big pluses with CELS is that it doesn't require any specialized training, and any surgeon can do it. It was first described back in 1993. It involves removal of polyps primarily endoscopically using laparoscopic surgery for assistance. This method allows us to avoid colon resection and the associated morbidity, and it's really evolved throughout the years since it was first described. It now goes by many different names and is performed in many countries. This technique is performed in the OR under general anesthesia with the patient in modified lithotomy. First, a colonoscopy is performed using CO2 for insufflation to identify the polyp. Then access is gained to the abdomen laparoscopically. So after laparoscopic access is gained, the colon is mobilized laparoscopically from its attachments. The polyp is then lifted, and then the colon wall is invaginated using laparoscopic instruments to bring the lesion farther into the lumen of the colon. The polyp's then resected endoscopically while the colon wall is visualized externally via the laparoscope. And then finally, the colon wall is sutured laparoscopically as needed for any concerns for perforation or if there's a full thickness burn. This technique can be used with many different modifications, so EMR or ESD, either one of them can be used to resect the polyp endoscopically. Some surgeons also perform full thickness excision of the lesion, and in that situation, the defect can be closed with laparoscopic sutures or with a stapler. This is a video of CELS technique for a right-sided colon polyp. So first, colonoscopy is performed to identify the polyp. And after the polyp is identified, access to the abdomen is achieved laparoscopically, and the colon is mobilized. First, the omental attachments are taken off of the colon. And then the right colon is mobilized laparoscopically from the right abdominal sidewall and the retroperitoneal attachments. After the colon is mobilized, the polyp is lifted, and through the laparoscopic view in the left upper hand corner, you can see the lifting material externally on the serosal surface of the colon as well. So after the polyp is adequately lifted, a laparoscopic bowel grasper is used to invaginate the colon wall, so that a hot snare can be used to resect it endoscopically in a piecemeal fashion. This is done with several passes of the hot snare, and each time the colon wall is invaginated with the bowel grasper. After the polyp is completely excised, some additional omental attachments are taken off the colon at the site of the polypectomy to allow better visualization of the site. And finally, the colon is oversewn at the polypectomy site to prevent full thickness perforation. So you can see that CELS appears to be an effective way to remove benign polyps endoscopically and prevent colon resection, but what does the data show? A retrospective review of institutional data was performed at Cornell of 75 patients taken to the OR for CELS between 2003 and 2012. Patients were referred to surgery if their gastroenterologist had failed to clear their polyps endoscopically. To be included in the study, they needed to have at least a year of follow-up and one follow-up colonoscopy performed at 3 months to a year after CELS. CELS was performed for these patients because their polyps were either large or they were located in difficult-to-access locations. These patients all had to have a preoperative biopsy that showed a benign polyp, and they had to have a benign appearing morphology based on the images on their colonoscopy. If after the lesion was excised in the OR, it was felt to be firm, or if it looked to be multilobulated, a frozen section was sent from the OR. Patients were converted from CELS to laparoscopic colectomy at the OR at the time of operation if the morphology was concerning, if the polyp did not lift, if the frozen section was positive, or if the endoscopic excision was technically challenging. The age of these patients ranged from 38 to 90, and the average follow-up was 67 months. Ultimately, 75 patients were taken to the OR for CELS in this study. 65 patients underwent attempted CELS, and 10 patients were immediately converted to laparoscopic colectomy due to concern for cancer on the appearance of the polyp. Of those patients in which CELS was attempted, 48 patients were able to undergo CELS successfully. 2 patients were converted to laparoscopic colectomy due to concern for cancer after excision of the polyp, and 15 patients were converted to laparoscopic colectomy due to technical difficulties. Of the 12 patients converted for suspected cancer, 4 patients, or about a third, were found to have cancer on the final pathology. The reasons for conversion were things such as ulceration, central umbilication, failure to lift on injection, or the polyps were firm or multilobulated. So looking at the chance of cancer based on polyp size, for all patients that that were included in the study, including those who did not ultimately undergo CELS but underwent colectomy, the chance of cancer does seem to increase with increasing size of polyps, with the majority of cancers found in the 3 to 4 centimeter range. Of the 63 patients believed to have benign polyps, only one of those patients was found to have cancer on the final pathology. None of the patients with high-grade dysplasia on their preoperative biopsy had cancer on the final pathology, and frozen sections were sent in the OR for 3 patients. All of those patients had benign pathology. These are the post-op outcomes for all patients who underwent CELS. The average length of stay was 1 day. The average OR time was 145 minutes. This average size of the polyp that was removed was 3 centimeters, with the largest at 7 centimeters. There were only 2 patients who developed complications, and those included urinary retention and a port site hematoma, and 5 patients developed a recurrence. Of those 5 patients who had a recurrent or residual polyp after CELS, 4 of them were able to undergo complete colonoscopic polypectomy at a follow-up. 1 patient underwent a delayed laparoscopic colectomy, but all of those patients had benign pathology. So when we look at all of the CELS literature as a whole, probably the largest and most current study was performed in 2016, which was a review of the literature looking at 8 studies that included 532 patients who underwent CELS. The most common location was in the right colon, and about 0 to 20% of patients, depending on the study, had cancer in their final pathology. In the larger studies that included greater than 20 patients, 73 to 91% of patients were able to undergo successful endoscopic resection, so pretty good success rate. The average length of stay was 1 to 1.5 days, and the recurrence rate really varied from 0.9 to 50%. So one of the major benefits of CELS is that it avoids the morbidity associated with colon resection, but another main benefit is the cost. So the average cost of CELS is about $5,000, and that's compared to about $12,000 for a laparoscopic colectomy or $20,000 for open colectomy. So performing CELS can save anywhere from $7,000 to $15,000, which is a huge benefit for any healthcare system. So in conclusion, CELS is a reasonable alternative to segmental colectomy for benign appearing complex polyps. It doesn't require any additional training, and any surgeon can do it. When the polyps are biopsied preoperatively, the rate of malignancy is very low. It avoids both the morbidity of colon resection as well as is associated with lower healthcare costs. Thank you.